So hello and welcome everybody to this PCR webinar supported by Abbott. And we are here today to discuss the diagnostic and therapeutic pathway in patients with tricuspid regurgitation. And I'm extremely happy to be joined by great colleagues, by Felix Greidel from Kiel, who is an interventional cardiologist as well as an imaging specialist, and Philipp Rake, who is joining online from Augsburg, who is a heart failure specialist and interventional cardiologist. So true interdisciplinary faculty today. My name is Miriam Wild from Freiburg. So today we will look at different aspects for TR diagnostics and treatment and discuss whether which patients to refer at what time point for the evaluation of TR, to discuss the current treatment options by the transcatheter approach, and also the role of different imaging modalities for the baseline evaluation, procedural imaging, and follow-up of these patients. And without any further ado, I would hand over to Felix for the first case, for this case-based discussion. But let me remind you that this is a very open and interactive setting, and we welcome you to ask your questions by the chat, and we will try to address them accordingly. So Felix, thank you.
Yeah, Mira, I'm very happy to be part of your team tonight, and I'm just directly going to jump into the case. I'm bringing you from Kiel. An 83-year-old female patient with severe TR. She was referred to us after a second hospitalization for decompensated right heart failure, and her past medical history was positive for permanent atrial fibrillation, chronic kidney disease, which we consider to be cardiorenal, and with recurrent upper GI bleeds due to duodenal ulcers. These were her lab values, and this is the medication she was on at presentation. And our absolute mainstay in further diagnostics, obviously, is echocardiography. I'm here showing you the TTE of this patient, the four-chamber view, and you can directly appreciate very dilated atria and a very dilated RV. And color Doppler information also is very positive of severe tricuspid regurgitation. If we then look closer and start to objectify our findings, which we highly appreciate, obviously, you see that the RV basal diameter was close to 5 centimeters. Even TTE already showed a coaptation gap of around 5 millimeter in the four-chamber view. And then next step, obviously, is quantification of TR, and this patient was found to have very severe TR with an ERA of 0.5 square centimeters. Her ECG, we've mentioned persistent atrial fibrillation. Invasive workup included a coronary angiogram that ruled out coronary artery disease, which is clearly shown. And then, very importantly, we did a right heart cath that was positive for post-capillary pulmonary hypertension. You want to always quickly focus on the wedge pressure, which was 24, mean PAP 28, and a cardiac output of 4 liters per minute that then calculated to a PVR of 1. Now, morphology, huge topic, mainstay of TOE. We like a 3D, and important is to make sure where is the landmark aortic valve here at 3 o'clock. Then you can appreciate a 3. Leaflet valve, pretty textbook-like. Biplane imaging from the esophagus, also very important. And here, just to pick one very important parameter, annular dimensions were found to be 4 centimeters, so moderately dilated. Then, this is really the eye-opener when it comes to assessing tricuspid morphology, the transgastric view. And you can again appreciate 3 leaflets. It's really a textbook-like tricuspid valve. And what is then important is to understand where is the least coaptation, where you have the biggest color Doppler information. And here I would say it was centrally extending into the anterior septal commissure, which is lower in the image. And also very important is to objectify the amount of coaptation deficit. In the slang, that is the coaptation gap, and this was found to be around 5 millimeters at the central part of the anteroseptal commissure.
So Felix, thank you very much for this nice case that you brought to us. And we would take a break here with the case presentation and ask you, how would you treat this patient? You're very welcome to participate in the poll, which is displayed in the chat on the homepage. So you can state your answer there. If you would either increase the diuretic dosage and reevaluate TR, refer the patients for a surgical annuloplasty, or go directly for a transcatheter treatment. And while you make up your mind and give us your feedback on the treatment, I would suggest we take one step back and go to the diagnostic workup of patients with TR. So these are the diagnostic steps that Felix presented for his case now. Giving the clinical presentation, including meds, of course, the labs, ECG, coronary angiogram, right heart catheterization, and of course, transthoracic and transesophageal echocardiography. And so I would like to ask Philip, does this reflect your clinical practice? Are you performing the same steps, more or less?
Thank you very much. So thank you for Felix for this perfect case. I think the workup is perfect. We would do exactly the same, though the patient needs really a thorough workup before we think about how we treat this patient at the end. So we need a good clinical examination. We need all the clinical chemistry, lab values, kidney function, etc., NT-proBNP. We want to, of course, have the ECG. We want to see if the patient has atrial fibrillation. I think it's something we need to discuss, and this needs to be addressed before we think about further treatment of the patient. We also, of course, want the imaging. I think the imaging is crucial. The transthoracic and the transesophageal echocardiography is absolutely super important to further evaluate the patient. And we also perform an invasive diagnostic. So we usually do a right heart catheterization. We want to know the invasive PA pressure. And I think an angiogram, that's something we need to discuss. So we usually do it when the patient has known coronary artery disease and did not have a coronary angiography in the last year. We would perform a coronary angiography if he has a dilative cardiomyopathy, and if the coronary angiography is more than 5 years ago, then we would perform a coronary angiography. Perfect workup, we would do exactly the same.
Great. And Felix, since maybe there are also referring physicians watching, like GPs or cardiologists, what do you recommend as the right timing to refer a patient for further evaluation at a heart valve center regarding the clinical, but also the echocardiographic evaluation?
Yeah, thank you, Miriam. Excellent question. Point in time, I don't think it's a very easy answer to give, but to start at one point, if patients are only presented when they're fully decompensated, it's obviously much more complex and may be too late. We know that our transcatheter therapeutics have their therapeutic range, and if RV and annular dimensions get too dilated, we just cannot treat them anymore. So there is kind of a momentum and an urge to present patients earlier. When it comes to diagnostics, I think it's absolutely crucial that the patient is in a compensated state. There is no need in doing this thorough workup in a patient that is fully decompensated. You will not be able to use the invasive pressure measurements. You will not be able to use the quantification of the TR. So you really have to make sure that everything else that can be treated regarding heart failure, also of the left side, needs to be fixed. And then you have the right point in time to focus on the right heart and the tricuspid regurgitation.
Yeah, and since you were mentioning the volume status of the patient and wanting to perform the diagnostics for a potential procedure in a compensated state, does this imply that you're hospitalizing the patients for the workup to perform the cath lab, the coronary angiogram, right heart cath, and also the TOE?
Absolutely. I mean, as we know, there's several ways patient can present. There's the emergency ward that will probably present more decompensated patients. There's referring hospitals that may have seen the patients when they were decompensated and have recompensated them. And there's the private offices that would send them typically also in a more recompensated state. But we look at that and evaluate that. And as said, if I see a patient that is firstly admitted via the emergency ward, I really make sure that the 10 kilograms of volume overload are gone before I really thoroughly look into invasive measurements or planning of procedures. We also know that even an annular dimension can decrease in a patient that has lost maybe 8, 10, 12 kilograms of fluids.
Yeah, sure. And there's I think the optimal world, and there's maybe the reality which can sometimes differ. So Philip, what do you think from your clinical experience? Are we seeing the patients at the right time point, or are we still seeing them too late?
So my experience is that we see the patients too late. I think it's really crucial that we think about these patients in an early stage of the disease, because if the disease is very advanced, the right ventricle is very, very dilated, it's difficult to treat these patients properly. So I think it's wise if we at a center can see these patients at an early stage via our outpatient centers and have a look at the patients. And I think the worst or the case is we see 10 patients and maybe in 2 patients we do something, but we offer that service for our referring physicians. And I think the point is really crucial to look at the patient in a recompensated state. That really has to be stressed, because we want to have the patient in an optimal situation with optimal diuretic therapy. And if the patient is still symptomatic, I think that's a good timing. And it's crucial to really see the patients early enough before the ventricle is really dilating. And I think it's the best point or the best timing for potential intervention in these patients.
Yeah. So maybe we will go to the poll quickly, and I think the audience online can see the result already, that the great majority, which might be of course a little bit biased in a PCR webinar, would go for a transcatheter treatment in this patient. So Felix, please tell us what you did in this patient.
Exactly. So this is how our local heart team decided. We wrapped up and said, okay, we have severe secondary TR, predominantly of a ventricular etiology, following post-capillary pulmonary hypertension. We consider this to be mid-stage disease, so certainly not very much down the road, but also not only moderate and early disease. And we found the patient to have favorable anatomy for a TEER procedure. And this is images from the procedure itself. I mean, this is a little bit showing off. This is not 2D, but 3D, and you probably pick up immediately this is online multiplanar reconstruction, but I'm showing you that this is also possible and beautiful, and you can appreciate that we're putting the first device in the anteroseptal commissure, and this is after grasping and closing. You can appreciate that posteriorly, so centrally in the valve, there's still residual color Doppler flow, and this is where we put another XTW tri-clip, and after deployment we were left with this really beautiful reduction, almost to no residual TR. This is further follow-up at discharge. You can appreciate easily that this is a durable and nice result, and so the patient went home on day 2. Short-term course was very stable. Then the patient, after 12 weeks, presented with upper GI bleed, and we were already worried that this was maybe associated with our TOE periprocedurally, but she was found to have recurrent duodenal erosions. And after they've been treated and her hemoglobin was stable, she had a very uneventful course with a significant clinical benefit. So at 1 year, she was really enthusiastic for her increased level of activity. Looking into the labs, kind of more deeper into what this treatment did to the patient, we could appreciate an increased renal and hepatic function, and I personally believe that the gamma GT really is a measure of disease severity of right heart function, and that was significantly improved after 12 months. Looking at the echo, after 1 year, it showed a very durable and still significantly reduced TR. We considered this to be mild, And if we try to objectify reverse remodeling of the right heart chambers, I'm presenting you here basal diameters. Remember, we had close to 5 centimeters at baseline, and after 12 months it was less than 4 centimeters, so significant RV reverse remodeling. And the same held true for the RA, not as pronounced, but also significantly to be documented. So if I wrap up this case, we had a classy 80-year-old patient with right heart-sided heart failure, based on probably a situation we would call HFpEF, and she underwent an efficacious TTIR procedure with very durable 1-year results, and that improved the quality of life and led to no further hospitalizations for heart failure.
Yeah, thank you very much for bringing this nice case. I think it greatly illustrates the complex context of TR patients and also the comorbidities, the codependencies of the diseases. And no, I cannot really draw, but I hope you see what I want to say. So we have the tricuspid regurgitation, we have liver function, we have renal function, and these are all codependent, so we have to keep this in mind, and I think not all clinical courses are as favorable as you showed it now. But when evaluating the patients at baseline with a cardiorenal or cardiohepatic syndrome and severely impaired end organic function or damage, is there somewhere a red line that you would not cross in treating patients?
Yeah, red lines is always difficult, as we know, but patients that have very late disease stage and are associatedly sick with a severe cardiorenal syndrome, I would probably be backing up. So really limited renal function or patients on dialysis, I don't think they can improve as patients with much better renal functions. Also, they have obviously not been tested in our randomized controlled trials, but on a very individual basis, I don't think I would say no in order to may improve volume management also in these very sick patients.
Thank you. Another comorbidity that we often see also being cause of tricuspid regurgitation, and a question from the chat is referring to pulmonary hypertension. So, Philip, what do you think about the context of pulmonary hypertension in TR patients and its impact on the treatment?
So first we have to, I think that's important to have a really thorough workup of the patient in advance. So if we have a patient which has, like in our case, which is a really typical patient with HFpEF and post-capillary secondary pulmonary hypertension and secondary right heart failure with secondary TR, that's a typical case, and I think that's a good, very suitable case for TEER procedures. Usually we have the cutoff of a systolic PA pressure of 65 millimeters of mercury. When the PA pressure is above that level, we usually don't perform a TEER or a procedure or an interventional procedure anymore. Patients with primary pulmonary hypertension and secondary right heart failure, we really don't know if that's a good patient, and in these patients we rather need to treat pulmonary hypertension at first, and I think that should be in the center. And the patient with secondary TR, post-capillary pulmonary hypertension, that's usually suitable patients for interventional procedures.
Yeah, and you also being a specialist for heart failure treatment, so in between the interventional and the heart failure world, and seeing both perspectives, where would you in general put the transcatheter treatment in this continuum of heart failure treatment and disease, and what medication do we have available in these patients with TR?
That's really a very important question which you're raising. I think the patient which has heart failure needs to really be understood. We need to do all these diagnostic workup in these patients. We need to, maybe we have a reason for the patient having heart failure. We need to treat that reason. If it's coronary artery disease, we might put a stent or send him to bypass surgery. And then we need to put the patient on heart failure medication. We have the Fantastic Four. We have excellent data. We can extend the lifetime and reduce mortality and morbidity in these patients if we do a really thorough pharmacotherapy with all these 4 established heart failure medication classes. And next step for me would be to look at atrial fibrillation. So if the patient is in atrial fibrillation, we need to manage atrial fibrillation at first, meaning getting him back into sinus rhythm by either preferably catheter ablation, pulmonary vein isolation, or if the patient is in permanent atrial fibrillation, we need to regulate his heart rate, and it should be in a normal range under atrial fibrillation. And then the next step would be to look for volume status, and we need to recompensate the patient. And then I think it's the time point where we are looking at other comorbidities, and that might be secondary mitral regurgitation and secondary tricuspid regurgitation, and then we would start treating these diseases. Usually, when we have a patient, I think this case we just seen is a very perfect case for isolated tricuspid regurgitation, a patient with HFpEF, but we have this huge number of patients with heart failure which have secondary mitral regurgitation and tricuspid regurgitation. So in these patients, we usually start with the mitral valve, wait like 2-3 months and see what tricuspid regurgitation is doing, and then we come back and maybe do a second procedure in these patients.
Yeah, Felix, does this correspond to your clinical practice, or would you also treat both atrioventricular valves at the same time?
No, I wouldn't be doing that. I think we kind of have the opinion, medication in TR does not work so well, but if we look on how well the patient also in the conservative arms did in our randomized controlled trials, we must do something better than 20 years ago. We all know slides with horrible Kaplan-Meier curves and patients dying very quickly with severe TR. We're not there anymore, right? So if we use a dedicated heart failure therapeutic concept for patients with TR, I think they already do better. And then we titrate in our interventional therapies. I think this is the way to go. That's also always the beauty of catheter-based therapies. We can titrate. So if there's severe MR, I would suggest to do that first and then see how that impacts on TR. If this very patient would then be left over with still hemodynamic significant TR, I would treat that. But like the basic rule of really trying to find those patients where leaky AV valves are found to be the driver of heart failure, I think those are the ones, be it on the mitral or tricuspid side, that we should focus on.
Felix, there is one question. We saw it coming from the chat, which is actually referring to your case presentation. Is there any risk score which is mandatory for tricuspid patients?
Yeah, I love the question. And as you said, I'm preparing a talk and I'm not even mentioning the scores. Honestly, I'm not a really big fan of scores. I know there's power to them, and maybe in patients that are kind of on the edge of being considered surgical patients or not, they may work. But in our clinical practice, I think in these patients, I'm very fond of relying on my clinical observation. I don't need a score.
Okay, so I think at this point we will go to the second case and we will tackle some of the topics that have already been discussed or are being raised in the chat. So I brought a case of a patient who is 80 years old, female, symptomatic, had a persisting AFib and also a 2-chamber permanent pacemaker. Her medication was a vitamin K antagonist, diuretics, and antihypertensive medication. The TRI-score was quite low, only 2%. She presented with peripheral edema, jugular vein distension, signs of right heart failure, and the right heart cath revealed no signs of pulmonary hypertension. This is her baseline echo. So she had this predominant right atrial dilatation leading to this annular dilatation with a coaptation gap. And she also had the pacemaker lead, of course, leading all of this to a massive tricuspid regurgitation. The biventricular function was overall intact. And here we see the TOE of the patient and also the lead position, the centrally located regurgitation jet. And so we would like to ask you again, how would you treat this patient? Now it's getting a little more complex because we're already warmed up. So would you go for EP regimen first, either by pulmonary vein isolation for AFib and re-evaluating TR? Would you extract the CIED lead if you think it impacts the valve function and is a main course for the regurgitation, possibly implanting a leadless pacemaker instead? Or would you rather expand the HFpEF treatment in this patient or go directly for a transcatheter approach? And while you make up your mind, we can maybe dive into the discussion, Felix, because maybe you can help us a little bit, being an imaging expert. What do you think is the problem of this patient?
It's not an easy question to answer, as I have not seen the transesophageal images yet. Maybe you can present them so we can go a little further in depth. Seems as if there is not running, but what we at least can see here is that there is a lead, and the lead is in a pretty atypical position, right? It's in the anteroseptal commissure. So we at least want to consider an etiology where the pacemaker lead is causal. You've mentioned that this to you was more atrial secondary FMR. And I would agree, and to that extent, that there's definitely annular dilation, that there's not too much tethering, so the leaflets are not heavily pulled into the ventricle. And other than that, talking phenotypes, this is a pretty also tricuspidly-like looking valve. So according to Becky-Hahn's classification, this would be a type 1. So huge atria, also huge left atrium. I'm pretty sure that there's a lot of atrial disease here. Regarding the pacemaker lead, I'm considering that in that unorthodox position, it may have pushed septally the septal leaflet a little bit. This is how I would look at it. Maybe one last point, if we focus on the Doppler, color Doppler information, we have to appreciate that it's actually not extending from where the lead passes through the valve, but more centrally. That could be a hint that the lead is a complete bystander, but maybe the lead at that position has altered the geometry of the valve to a certain extent that you have find yourself with that central coaptation deficit. So interesting case, predominantly atrial, maybe a little bit of interaction with the lead.
Yeah, so it's definitely a complex case with different aspects. And if we look at this patient only at one time point, I think we can agree it's often very difficult to say what the etiology is. We can describe the phenotype, but it's very difficult to say what came first in a patient. And looking at the poll, there was a lot of movement, actually. And so 1/3 of the audience thinks that they would go for a CIED lead extraction first and really re-evaluate the valve function. 17% would go for medical therapy and expand the HFpEF treatment, and half would treat TR by a transcatheter approach. So, Philip, what do you think about these results, and how would you treat this patient, and why?
I think it's a good discussion because you see the patients are so different, and this is really a complex case with a lead, with a HFpEF, with atrial fibrillation. She has a large atrium. So I think the basis should always be treating HFpEF. We have SGLT2 inhibitors, we have diuretics, we have new therapies on the horizon. So I think that should be the basis. For treating atrial fibrillation, if we follow my previous course, I would not be too enthusiastic in this patient because she has a really large atrium. So I think if we get the heart rate controlled well in this patient with 80 years of age, I think that should be a good, this is what we can reach in this patient. For the lead extraction, I personally think that this lady is 80 years old. It's something we have to discuss, of course. Usually leads in general do not hamper us doing these kind of therapies, interventions on the tricuspid valve tear or TTVR, because usually the lead is somewhere in the commissure, usually the posterior septal commissure, very posterior. So it does not really interfere with the tricuspid valve and with the potential procedure. In this case, a little bit different. I go with Felix that this lead is in the anterior septal commissure and it's touching a little bit the septal leaflet and maybe pushing it a little bit to the septum. But this very central posterior is questioning if that's really the reason, the lead. So I would personally not go, because he's 80 years of age. So this is a really invasive procedure, a lead extraction, and potentially you have to replace the tricuspid valve in a complex surgical procedure. So I would personally think if we have managed heart failure well, have a good heart rate control, then I personally would discuss with the patient for going for an interventional procedure.
So Felix, there are actually a lot of questions in the chat regarding the time point of an intervention. So around this sweet spot, so-called, for transcatheter treatment in TR patients. And do we have anything on hand except the TR severity, like RV function parameters by hemodynamic assessment or by echo assessment? And one of the participants is also referring to the results from the ReShape-HF trial, considering an earlier treatment in MR, so in mitral regurgitation. Do you think that we will get to a point where we will possibly treat moderate or moderate to severe TR patients if they're symptomatic?
Excellent questions, and not so easy to answer, of course. From a very general standpoint, I'm reluctant to treat patients that have no symptoms. So if you have asymptomatic patients and you even have severe TR, you always have to consider how fair is it to take the risk of an intervention. So you really need to have prognostic benefits associated with our therapy to say, okay, let's treat this patient due to a failing RV or RV dilation if there's no symptoms. I mean, obviously we would expect a dilating RV and very severe TR to be associated with symptoms, but we all see these patients that do well under medical therapy. So I think it's always a so-so situation with jumping in early, of course. You want to prevent a negative course, but on the basis of our experience yet, it's a pretty pushy standpoint. From interventional side, I think early is easy because the less dilation you have, the more meticulous and excellent your repair can be. So one cutoff could also be a certain degree of dilation that you say, okay, I'm following up this patient and annulus is dilating more or the gap is dilating more and I want to jump in before I cross the lines which we think are speaking against the TEER procedure. I'm very fond of TEER, obviously. As we know, it's super safe, it's very controllable. So TTVR, obviously, it extends your therapeutic reach, but this is very early. So when considering TEER, I would say less symptomatic patients we can follow up and jump in when things start to dilate significantly.
Yeah, so I think we can agree that TEER is a default strategy today and probably will remain so for some time because we have a lot of experience. So Philip, you also have a lot of experience with TEER procedures and tricuspid patients. And if you see the TOE pictures, what strategy would you pursue in a procedure? So the patient is already lying on your table. You've been on holiday last week in the heart team discussion, so she's already there and you're just seeing the pictures. What's your approach? How many devices would you plan to place where?
So in this case, I would, so if we have come to the decision that we go for an interventional procedure, I would go for a TEER procedure in this case. And I would, personally, I think that's a very central posterior jet. So I personally would go for a Clover technique in this patient. So placing, usually we place a device in the anteroseptal commissure, between anterior and the septal leaflet. Sometimes we have to place a second there. We look at TR, look how the tricuspid regurgitation result, our intervention result is presenting. If we're not satisfied in this case, I would personally go, if we have placed one anteroseptal device, I would place a second device in a posterior septal, because the jet is extending into the posterior septal commissure. I think that would be my first choice, would be an anteroseptal device, and then see the result and maybe go for a Clover technique with a posterior septal second device.
Yeah, thank you very much. So we will just quickly go back to the case, and I will just show you the procedure. So as you pointed out, we would always start in an anteroseptal position in the majority of cases. Also due to the imaging, the first device, if you plan to go for an anteroseptal or a Clover technique strategy, you start with the anteroseptal device. So this is what you see here, the leaflet grasping and capture in this position. And this was actually also already the final result in this patient, because it was very satisfactory even after placement of one device, although we had originally planned to go for a second device posteroseptally, as you also explained. And in this case, we caged the lead in the anteroseptal commissure. And it was an uneventful clinical course, and TR was reduced to mild to moderate with a mean gradient of 1. So this is I think, a quite satisfactory result. Felix, what do you think is the aim that we have in TR procedures? What is the goal of the procedure, and how can we estimate in some way if we can reach it?
Very good question. Before that, let me quickly comment on your beautiful case. Maybe the fact that an anteroseptal interaction proves that the lead that was also anterior had some causal interaction with the coaptation. Very interesting. So what do we want to achieve? We want to achieve a durable reduction of TR. This is really what TR needs to deliver. There's obviously no need in having a good short-term and then a bad long-term result. We want to reduce, ideally to at least moderate, better to mild TR. I think we have signals from our registries that patients do better with the less residual TR possible, and we want this to be a durable result. How do you measure result at the end of the procedure? And we all know that if we're standing there and we've fought hard, our level of interpretation is somewhat different than it is the following day. But I mean, you obviously look at color Doppler information. If you want to be meticulous, you do vena contracta area. You really have to rule out that you create new jets or eccentric jets. So again, that's the mainstay of echocardiography. Also, last comment, I'm very fond of measuring RA pressure. And if we reduce V wave and RA pressure, which we don't do all the time, which is difficult in huge atria, but if we see that, I have a very positive feedback that we've done good.
And Philip, one question from the chat is whether to go for a TR procedure or an annuloplasty in TR patients. What do you think about this device choice?
Yeah, that's a very difficult question. I think we have very good established options for direct TR procedures. We have good data on these from two. For TR, we have 2 randomized clinical trials which have shown that patients have an improved quality of life. I think annuloplasty, all the devices available are still in a position where we do not know if that's really a good strategy. So we had some experience with annuloplasty. Usually the results are not satisfying. The procedures are very intense, taking long time. So I personally prefer TR procedures at the moment, or TTVR, depending on what the morphology of the valve looks like. So I think the way at the moment and how the evidence we have is very strong for TR procedures at the moment. or TTVR.
Another aspect, just a short question, short answer, about the procedural assessment or the result is the gradient at the end. And we are very aware of the gradient coming from the mitral side. And how do you, what role does the gradient at the end play in the TR treatment for you, Felix?
I mean, we do look at the gradient, but honestly, I couldn't recall a single case where the gradient was too high. So in the tricuspid space, we have a different situation in the mitral space where you easily create a high gradient, easily reduce opening area significantly. In the tricuspid space, you have just very big anatomies, and it's really tough to create a higher gradient.
And speaking of big anatomies and large gaps, I think you brought us another very interesting case.
Yeah, thank you for that, Bridge. And it's an honor to present another case I'm bringing from Kiel. And that's, as you will learn, kind of a special one. We're talking an unusually young female patient with very severe primary TR. She was referred with as symptomatic. She found herself in New York Heart Functional Class 3, and she was found to have chronic ascites. A wild past with a status post-intravenous drug abuse, and the patient was still on analgetics abuse. Post-capillary pulmonary hypertension, but only mildly. Other than that, no relevant findings. That's her labs, and that is her medication. And sorry, I have to correct myself. What I didn't mention here was to focus on the slide is that she had basically no peripheral venous veins that could be accessed. So this is mainstay diagnostic echo, huge RV, hypercontractile function, huge color Doppler jet information. You can, even without lowering the baseline, you can appreciate a huge PISA radius. This is 3D TTE. We're very fond of doing that to get a good estimate of systolic RV function. Here, tracking is pretty good of that 3D RV, and in the lower right you see EF is calculated to be close to 60%. Now morphology, obviously huge color Doppler jet extending kind of from the posterior part of the valve. This is workup by 3D MPR, and the right upper box, the red one, cuts the valve from the septum to the lateral wall in the posterior aspect of the valve, and you can appreciate in the upper right box that very dull and shortened posterior leaflet. So this looks really as if the posterior leaflet was eaten away at some point in time. When we saw this patient, there was no signs of endocarditis. So again, here, this is transgastric, just to show you how we look at it: posterior septal commissure, anteroseptal commissure, anteroposterior commissure, and in between, and then the posterior leaflet, which is obviously here. You can't really appreciate that very nice echo-rich leaflet edge. So, Miriam, you want to ask our audience? Thank you.
Yeah, so as you see, we're increasing the complexity of the cases and also of the polls. You have several possible answers, and there is no wrong one. So please, you're really welcome to just give us your opinion, and even if it's just an intuition of some sort, just give us your thoughts. How would you treat this patient? What do you think? And meanwhile, I will ask my colleague Philip, what do you think? How would you treat this patient? Philip might not be there anymore, and I cannot really ask him. No, he's here.
Yes, I'm sorry. So this is a very special case. It's a young patient, 52 years of age. She has an IV drug abuse, which is the cause, obviously, of this primary tricuspid regurgitation with endocarditis in the past. So I personally think she's not a good surgical candidate. So she has no IV line placement is really difficult peripherally. She is not a good surgical candidate in my eyes. The valve is really destroyed. So TEER procedure, very difficult. So I think the only choice, and if we're talking, so we have to discuss this patient, of course, in the heart team. discuss with the cardiac surgeons. So I mean, primary tricuspid regurgitation would be obviously a case for the cardiac surgeon, but in this case, with this IV drug abuse, maybe the patient is not really compliant. We don't know. It's a difficult question. So, and discussing surgery for primary tricuspid regurgitation has high mortality. So we're still talking about almost 10% mortality when a patient is treated for the isolated tricuspid procedure surgically. So that's something we have to discuss. So I personally think it's not a candidate for surgery. I think it's a candidate if she's willing for an interventional procedure, but not for a TEER procedure. So this, in my eyes, is a case for a tricuspid replacement therapy interventionally. So we have the option of orthotopic or heterotopic valve replacement. That's something to discuss in this patient. Imaging is important. I think that's besides echo, we of course need more imaging, and that means we need a CT to better understand the morphology, and then to decide which procedure would be suitable for this patient.
Yeah, since you've already mentioned the imaging, I think, Felix, you nicely showed the possibilities of advanced imaging and multimodality imaging. And I know that you're fond of different imaging modalities, but is this really something that we should use in our daily practice, and in which patients, or all patients, or is it something more for academic purposes?
Thank you for the question. First of all, obviously you need, if you're talking echocardiography, which is our mainstay imaging modality, you need to make sure your T images are as good as possible. I mean, fancy 3D MPR doesn't compensate for bad acoustic windows, shadowing artifacts and all that. But if you are really decent from a technical standpoint, then those advanced echo modalities like 3D, they really help you. You can get a very good idea on the whole, on the dimensions of your landing zone. If you're talking TTVR, in this very case, we nicely worked out how big the coaptation gap is, how the posterior leaflet was missing. So I can only appreciate very much. Next step could be that you have these 3D volumes and then have automated algorithms, AI-based, that help you in measuring dimensions and leaflet areas very quickly.
Mm-hmm. Yeah, so now there was also a lot of movement and like silent discussion in this poll actually, and there still is some movement, so people are still making up their minds, but I think we will conclude now, and I can see that the majority would actually go for a surgical valve replacement in this patient, followed by transcatheter edge-to-edge repair, which I think is really interesting that 1/4 of the audience would consider this patient suitable on an anatomical level for a transcatheter edge-to-edge repair. Philip, what do you think about this?
I think it's not suitable for a TEER procedure. The gap is really huge. So when we're talking about TEER procedure, usually we say if the gap is larger than 10 millimeters, we cannot place a TEER device properly in these patients. So when the gap is larger than 10 millimeters, the valve is really destroyed by the previous endocarditis. So you don't have really good material to grasp when you place a TEER device. So personally, I would not recommend a TEER procedure in this patient.
So of course it would be a nice twist if it were actually a surgical valve replacement case, Felix, but maybe you can tell us why it wasn't and how did you treat the patient?
Exactly. Just to refer to the heart team discussion, obviously we were also not easy with the idea to treat this young patient with a very new catheter-based replacement therapy. But one of the very strong arguments we found in our heart team discussion was that if this patient had better veins and was a surgical candidate, would we treat her with a mechanical valve? A patient that still has compliance problems, is still on And abuse of analgetics, probably no. So we thought catheter therapy regarding a biological valve concept was really a relevant competitor to classic surgical therapy here. What do we do? Jumping back to multimodality imaging, if we consider a patient for valve replacement, orthotopic valve replacement, you need to do a CT, gives you the best spatial resolution of the valve structures and the surrounding structures. This is what we did, and for this very device, the evoke valve that we considered in this patient, you see there's green information, so sizing was just right. This is a patient with a perimeter-derived diameter of 48, 49-ish, and there is a valve that can treat this anatomy. Now we jump into the intervention already, and this is also regarding imaging. I think a nice spotlight. So you've done the CT some weeks before, then the patient goes home, and before you then implant a valve, you obviously want to make sure that you're still referring to the same dimensions, and you couldn't redo a CT. So this is again where we use multiplanar reconstructed 3D volumes of the echo. This is for those of you who may not have seen this. This is how we insert the delivery system into the right ventricle. This is a stiff working wire. This is the big catheter that carries the big valve stent. And then interacting with the valve leaflets, it's all guided by echocardiography. And you can tell here we typically use multiplanar reconstruction of a 3D volume. If you focus at the very tip of the catheter, you see that the grasping legs of that valve stent are starting to be developed. If I jump to the next slide, you see that they have already developed further and start to interact with the leaflets, and then you make them flip. And this is where this device works similar to a tear device, actually, as it tries to grasp leaflets, and you can understand that we were pretty interested in how this valve would grasp that deteriorated posterior leaflet. Intervention goes on. You see the whole valve stent is almost fully developed. Next slide, you see the fully deployed valve looking beautifully by 3D in the lower right panel. And then a brilliant question is obviously, is there paravalvular leaks? And there surely is no severe one. But if you look at the lower right panel at 1 o'clock, you see, yeah, there is some color Doppler information stemming from the interior aspect of the valve. And this is just interesting how these devices work. You can appreciate here just at the anteroseptal commissure, there was one grasping leg of this device not interacting with leaflet. How could it? Typically, you don't see this. Our idea was in retrospect that we were trying to support the posterior part of the valve more than we usually do, so that's why we were left over with this anterior tiny PVL. Fluoroscopy, this is discharge, and this is 3D RV function at discharge. Interesting, reduction, EF is here calculated to be around 25 to 30%. That seems to be very low. Interesting discussion point, obviously, why is this? But after 4 weeks, we had this patient for a follow-up MRI. This is not what we do in every patient. Here we had the chance to do it, and this proves just in a massive reverse remodeling. I think this is really beautiful images. From 400 down to 170 milliliters RV became almost as big as the left ventricle. And RVF, that I would interpret was hypercontractile at baseline, is then pretty much in the normal range. So finishing off, peri-procedural course was very uneventful. Patient was discharged home on day 5, and the only new medication we put her on was lifelong anticoagulation with apixaban. And after 30 days clinical follow-up, the patient was well and significantly better, improved in her daily activities. Thank you.
That is a great case for the end of this webinar. Very complex and also a different treatment approach. And I think we could have an entire webinar only on transcatheter tricuspid valve replacement. But maybe let's have some short discussion points. There is also a question in the chat about the antithrombotic regimen. after TEER, but also after valve replacement. So you went for a NOAC in this patient lifelong. And how do you treat these patients in general?
Yeah, so TEER patients are different than TTVR patients, obviously, regarding the amount of foreign body in the valve. In TEER, it's a pretty easy call, as the great majority is in atrial fibrillation anyway. It's only those patients that have maybe LAA occlusion where you start to consider, do I need a DOAC for the TEER devices? Probably not. We have these patients on a single platelet inhibitor. TTVR, in the very beginning, we thought we needed to be all in and put the patients on vitamin K antagonists and then actually experience bleeding complications. This is as recording to your drawing. There's hepatic problems in putting the patients on a difficult to monitor anticoagulant substance we felt was not adequate. And with apixaban, I think we've kind of have a good spot, as opposed to the DOACs you only give with a single dose daily. We think it's good to have a pharmaceutical that is given twice daily. And regarding the duration, then again, most of the patients have AFib anyway, so they're on the DOAC. This very patient was in sinus rhythm, interestingly, but still we decided to have her on apixaban lifelong.
Yeah, so I think we already learned in the rather short course for TTVR that we don't need additional antiplatelet therapy in these patients, and that anticoagulation monotherapy is sufficient. But still, would you follow up the patients with a CT scan to detect HALT or thrombosis?
Very good question. We typically do not do, but we do a meticulous echo workup, and if the gradients increase unexpectedly, I would very quickly call for a CT to rule out HALT or thrombosis. Yeah.
And I think the elephant in the room is, of course, the young age of the patient. So she was only 52, as I recall, and we do not know much about valve durability. So Philip, what would be your expectation for a valve durability, and what could be a possible bailout strategy in a patient?
Yeah, that's a difficult question we cannot answer at this time point. And this is really, I think the discussion and the poll results are really important, because I think it's the young age of the patient is the important issue. And I think the discussion with the surgeons and the heart team is really important, because I think as the patient was managed by a TTVR procedure is fine, a surgical procedure would be a discussion point. I would not have gone for this direction, but I think it would be a valid option too for this patient. I think personally that everything with tricuspid is really, there's a high thrombogenic risk. So we have to, I would personally put this patient on vitamin K antagonist, at least for 3 months, maybe longer. Just to be sure that there's not a valve thrombosis is a big issue, I think. In this patient, she has a high risk of getting re-endocarditis because she's an IV drug abuse patient. So I think that's something which needs to be considered in this patient, which I think it's important to have support in this direction, that the patient gets off her IV drug abuse. I think that's really important. I personally would follow this patient really closely by a transthoracic echo at least every 6 months. If there is any doubt of valve thrombosis, we have to go for CT imaging. And bailout strategy in this case, if we have a valve deterioration after some years, might be a valve-in-valve procedure. I think but it's something is this lifetime management for these patients? I think we have for aortic stenosis, we have big discussions, lifetime management. And I think this is a new population which we are looking at with tricuspid regurgitation, and lifetime management is really important in these patients. And the young age is an issue in this case. And I think it's something you need to discuss in the heart team and with the patient. And close follow-up.
So I think this discussion could be ongoing the whole evening. Unfortunately, we have to continue afterwards, Felix. So to wrap up, I think this was a great webinar. I thank you both very much for the contributions, for the great cases that you brought. I think that we really saw the broad spectrum of TR patients, that there is not one size fits all strategy, that it's always a patient-based and individualized treatment plan that we have to make, that we have to follow up these patients, that we need the multimodality and dedicated imaging, that we have to use the different modalities for this. And of course, again, emphasizing the importance of the heart team approach, the really interdisciplinary approach with the heart failure specialists, interventional cardiologists, imaging specialists, and also more and more the EP community in these patients. And I thank you all from the audience also for your participation, for your great question, and thank you very much for watching. See you soon.